Hi, welcome to this week's episode of the Modern Patient Experience. I'm your host, James Furbush. Really excited for my guest this week joining the show. Going to be talking really important topic that comes up a lot with executives on when we do this show, and that's health equity. And my guest this week is Dr. Josh Liao. He is an internal medicine physician and the newly appointed associate chair for health systems in the Department of Medicine at UW Health. And he's also the founder of VESSL, which stands for the Value Systems Science Lab. Josh, thank you so much for joining us this week. I'm really excited to have you on.
Likewise, James. Thanks for having me.
Yeah, you've got a lot going on. And so, I'm sure you can explain it a lot more eloquently than I can, but can you kind of just give guests an overview of your work at UW Health and the University of Washington?
Absolutely. Yeah. And some of the naming is a little confusing, but the health system we call UW Medicine. That's what I'll refer to kind of here going forward. But so as you mentioned, I'm a clinician practicing internal medicine physician there. Outside of that, I lead a body of scholarship and evaluation. That is what's powered through VESSL, the Value Systems Science Lab. I also serve as the enterprise medical director for payment strategy for UW Medicine. And in that way, we try to think through issues of payment and how it cascades care delivery and many other kind of related topics for our system and our kind of regional partners and populations. And then the last thing I'll say is I'm fortunate to, be able to engage a number of regional and national decision makers in terms of how do we think about these policies. So I steep quite a bit in how do we design policies that can lead to programs and outcomes that we want.
That's incredible. And so when you're not doing all this, I'd love to start out, because it's also another sort of tangentially important topic, but, what do you do to sort of recharge your batteries and prevent burnout? I mean, you've got a lot going on and I'm sure you're very busy professionally, but how do you sort of keep that all in balance?
Yeah, well, I'd say two things. The first is, I'm fortunate to live in the Pacific Northwest where we have just a wealth of places outside to get outside the office and spend time. And I love that part of life. And, one of the reasons I love living here, that's on a personal level. I think professionally too, I'd say that as maybe tried as it sounds, I think our best efforts and our best results end up being close to what we're passionate about. And so you mentioned I have a lot going on. I'm fortunate definitely to do what I hope is important and impactful work. But the other side of that is the work that I'm not doing, the work that I could be doing, but I feel like is not the closest to the values and the passions that I have. And I think that for me personally, that's very important to prevent burnout and to drive wellness is to make sure that as much as I can, I'm staying close to those passions.
That's awesome. It's really good advice. I will say I lived in Portland, Oregon for a time. And speaking of the outdoors, it's the one thing I miss where you can be 15 minutes outside the city and you're like, oh my God, I'm in the mountains or like a rainforest or just some other environment. I definitely don't get that here in the Boston area where you got to go quite far to find that. But yeah, that's exciting. Do you have any favorite places you like to go when you're in that Seattle area?
Yeah, a few. I think have a family. And so what I do with the children is a little bit different than what I'm able to get out on my own. And I think, the principle behind that is, again, as cheesy as it sounds, like you really can't do work over the long term if you're not recharging your batteries, if you're not taking care of oneself. For myself, actually, one of the things we're heading into is winter steelhead season. So for people not in the Pacific Northwest, maybe less familiar, but I mean, long story short, these are adult fish that make their way out of their native streams out into the ocean, leave North America, come back. And, if you can brave the winter in January, February and go out there, in freezing rain and sometimes snow, you can catch some of these, right? And it's just nothing like it. I really enjoy it. So that's one specific thing I like doing.
That's awesome. We could probably talk outdoors and fishing quite a bit, but actually we're here this week to talk about health equity. And I want to start with just really for you, can you sort of just simply define and sort of talk about what is health equity? Because I think it's important to level set where it's a term that gets thrown around a lot. A lot of people have grasped onto it as an important thing and certainly the last couple of years. But I, think it's always good to level set and sort of have that sort of comment, what are we talking about when we talk about health equity?
Yeah, it's a great question. And I'd frame it in a few ways and say that I think what you're putting your finger on is that it's an important issue to a lot of people because deep in our guts, our intuition is something is really unjust and inequitable about health and healthcare. And yet there's so many perspectives to it, right? So the way I think about health equity, I'd step back and say, what is health? And on a broad level, I think it really is physical, mental, and social well-being, right? Not just the absence of disease or infirmity. And when we then think about what is health equity, to me, it is ensuring that all people and populations have a fair and just ability to live healthy lives And if you then take that and think about what inequity is, it's anything I think that combats that, right? And many of the things we might talk about today, I think within that framework, but it's important to recognize it, not just on the principle, but because so many people from so many perspectives, right, grapple with this issue. And I think that's partly because of how big this issue is, right? And how kind of cross-cutting across healthcare, as well as mental, social well-being, I think it is.
Well, I mean, it touches everything, right? I mean, social determinants of health and so many costs, and it's huge. Like when you really kind of boil down to it.
That's right.
How did you get interested, starting in sort of this topic of this area of interest for you? I'm just curious what precipitated for you sort of this passion for this topic.
Yeah, I think it's grounded in a few things. I think one, without going into kind of painstaking detail, the origins of why I wanted to be a physician. And related to that, I think what I saw as a physician early on in my training and career, and now what I continue to see, I think for me personally, it's incredibly motivating and important to be close to that, to be close to patients, but also in that patient care, recognize that most of the time these people are living their lives outside of the healthcare system, and to see how what I do with and for them intersects with their lives, right? So I think that's like an incredibly important thing. And, maybe the short way of saying how my career outside of clinical medicine has progressed is to be able to say, I want to literally and figuratively be at the table to be able to advocate for these groups, to see a more equitable system. And to do that, you have to get into this big, complex thing, right? And I know that I'm only going to add, my few verses to the proverbial grand song, but this is, I think, where I have passion. This is where I think I can hopefully have impact. But we're going to need work, right? And effort from many other people to do that. So it is grounded in those values, carried out over the career, and recognizing that I contribute one piece to what I hope is many pieces to address the problem.
Yeah, that's fantastic. Do you have some examples just as well, right? I mean, because I think there are some obvious examples that might be easy to look at, which, the one that comes to my mind almost immediately is, I think it's like the proportion of like African-American women that die in labor, right? Like there's a huge discrepancy between those rates of death versus Caucasian women and other populations. Do you have some examples like that to sort of illustrate the problem? And then maybe even some more subtle ones because I think sometimes too, the subtle ones are sort of the more interesting discussions where, you can say, well, that actually is, not equitable. And it's hard for people to kind of sometimes step back and see why that might not be the case.
Yeah. So, man, that's a great question. What to say about that? I mean, I think the most important, right? I think the most important,
it's a big open-ended question. Unfortunately,
but just a simple question is, yeah, thanks for that.
Yeah.
No, I think it's important to really touch the contours of the quote common or the obvious ones, because even if issues are obvious, the drivers behind that are not so obvious. For people like myself who work on health systems, one of the key, the fuel for that work is to be a quote systems thinker, right? Which is to think about all the interconnected parts of systems, plural, right? That lead to these outcomes. So take your example, like why are those outcomes disparate, right? And I think if you ask 10 people, you probably get 10 different answers, and many, if not all of those are right. And it just highlights that. So, that idea of subtlety or like less recognized, I wouldn't actually just say there are some that are clear and then we know it fully, and there's some that are subtle, we don't know them. I'd say even the ones we think we know, the drivers behind that are like less clear. And, I want to loop back a little bit to something you said about social determinants. 20 or 30 or 40 years ago, the conversation, it's evolved. It wasn't there. Even in my career, I've been able to see the evolution of that, right? The elevation of, hey, social determinants, intersections of how people might be marginalized. And I think those are really critical to when we think about these issues. So, I think, let me just say simply, there are subtle or under-recognized drivers or facets of even very obvious or flagrant inequities. That's one. And then I think, when I think about the things that are outside of that, I would say it's in that way. It's in the kind of what layer we're talking about, and then the intersections between them. I think you highlighted race, right? And race ethnicity are incredibly important dimensions of equity or inequity, but they intersect, right? With income, education, language, lived environment, a number of different things in and outside of healthcare. And so I think if we consider the issue as there's a racial inequity, that gets us progress, but there's more. And I consider that subtle, although I think it's important. And I think that's where the conversation needs to go, right?
Yeah. I mean, I don't even know how to even begin to like unpack all that, because it is, but and maybe like the follow-up is, how do you think about sort of what we need to do to sort of move that conversation forward and actually make change on this front? Because I know a lot of there's payment issues. You've talked before about the shift to value-based care actually didn't factor equity in. It was really about access and cost and not actually equity. That's like one area. There's private institutions that have a role to play. There's public institutions that have a role to play. And so maybe in the short term, I mean, where do you want to see this conversation move towards?
Yeah. I think it's important to say, if we step away just from health equity for a half second and say, when you look at progress on other fronts, you don't need every single person, every single group across an entire massive multidimensional community, right, to clasp hands and push forward. If you did, probably very little would be done in healthcare. No, I mean, really, right? Yeah. And so I think you can identify key players, key stakeholders that need to be there, right, to drive the conversation. You mentioned value-based payment. In my opinion, I think Medicare over the last decade has been a very important driver in that, both in kind of explicitly saying, hey, this is where we're going, and then fashioning programs, right? Some are voluntary, some are required to do that. Have others followed? Yes. Has that banner, so to speak, helped people move in that direction? Absolutely. But I think we want to be careful in the origin story of movements or trends to say, well, it was because we all recognized this had to happen. I don't think that always is the case. I suspect that will be the case here, right? That if we wait until we can, pull a lever and fix it all, I think we'll be paralyzed and very little progress. But who are key players in different spaces of the healthcare community that can make incremental but meaningful gains? I think that's the way I think about it, right? And in that way, in that prism, then different groups are going to have to do different things. Some will be complementary and synergistic. Some may not be, and that's okay. And I don't think we need that complete consensus to then move forward.
I mean, if we've learned anything probably in the last 10 years, getting that complete consensus probably will never happen.
Agreed.
And we will be paralyzed. Yeah. So then I'd love to just unpack, your thoughts on some of those different players. Our audience obviously is mostly on the provider space, right? Like hospital and health system executives and things like that. But, I'd love to just hear, if you could kind of go through what role, each of those maybe players have and how they should be sort of thinking about this problem as they start to really dive into it.
Yeah. So I'll loop back around to providers and provider organizations. I think public policymakers, entities like Medicare and CMS, I think play an important role. Just as I mentioned, they played an important role in value-based payment. I think they'll play an important role here. I think the most recent information that they've released suggests that they have a clear intention to do that with respect to equity, which I think is appropriate. I think is good. And you and I don't have to look very far to identify examples in which the quote private sector or other groups have followed the lead of CMS, right? And state Medicaid programs. I think that's critical. We can unpack that. But I think in policy setting, and when it comes to payment, in how do you design the incentives and the payment programs, incredibly important. We need that. I think provider organizations, I think there are two different directions, and I'm not saying anything new. I think there are examples of people doing it. But one is to say within more traditional healthcare delivery, the quality of healthcare, the extent to which delivering care to people affects their health, right? Because we know with social determinants and everything else, there are other things right outside of the healthcare sphere. But within that piece, what are we doing to drive equity? Then there's a few things they can do related to kind of measurement, programming, et cetera. We can get into that. But the other kind of segment there is how are they going outside of healthcare to partner with communities, other groups, community-based organizations, et cetera, to begin to edge away from healthcare purely and to say healthcare touches up against and is adjacent to many other things. And so how can we create new programs to do that? Housing, food security, et cetera, et cetera. So I think for those stakeholders, it's incredibly important to update what they're doing in their traditional business and then edge into adjacent spaces to address equity. I think outside of that, I think public policymakers have a critical role.
Yeah. So, suggesting really kind of partnering places, food banks, churches, the places where people spend a lot of their time and have that sort of community where they use that. Did I sort of understand that correctly?
That's right. And I mean, I think you can take a quote portfolio approach here, right? Which is to say that you don't need to do that to the exclusion of what you're doing more traditionally related to quality of care, patient experience, delivery models. I think it's a both and. I think the other thing is, healthcare often, if not always, is hyper local, right? The needs in Boston where you are and the needs in Seattle don't have to be the same for groups in both of our kind of regions to be thinking about access, spiritual communities, community touch points, the things you're highlighting, right? So I would love to see that. And I think that's absolutely one piece of the portfolio. Yeah.
Cool. And so then I think payment reform and some of these, what are these other pieces of the portfolio that would be would be critical to consider?
Yeah, I don't want to oversimplify something, but just to help us kind of put our arms on it a little bit. The reason I have worked on it from the perspective of payment outside of my background and expertise is that I think payment, although not the only motivator, is a very powerful motivator. And so I don't see that as like next to delivery and community partnerships. I see that as like behind it. It's like upstream of it. And so how we pay for care heavily affects how we then deliver care and the programs we do. And importantly, James, the programs we don't implement. Right. So I think payment is a key thing, but it's like that factor that drives so many others that we're talking about.
Moving off of fee for service and doing things like bundled payments and it did really, I think, did sort of change some of the behavior, not all, but, it starts to inch it forward, sort of that care delivery and thinking about that. Can you help me understand how equity and payment, how we would change payment or think about that sort of payment mechanism to incentivize equity as a equally important part of that discussion?
Yeah. So not to kind of be like a one trick pony and keep saying that there's multiple levels, but even when we think about payment, there are multiple levels, right? So what you're highlighting in some ways is coverage. How do we pay for or cover people's ability to get health insurance? Well, I think one of the challenges is once you cover people, you have to figure out what are you covering? And then is the delivery of those services the most cost efficient and high quality, right? And thoughtful that it can be. And so there are these levels, right? And then within those levels, you have specific payment models like bundle payments, et cetera. So they all play a role. They kind of fill out the environment, but I think it's important to think of those as multiple different perspectives. I think across them, though, I'd highlight a few principles. One is to set an intention to look at equity. And the reason I say that is that I think it's appropriate to say, I want to get the most proverbial bang out of the buck, and the most quote ROI and the best quality gains out of any program. But I think there's been less attention to, do I get the most even bang for my buck? Are all the populations that I serve equally being beneficial? And if I was to get, 20 points of benefit in group A, but only 2 in group B, is that okay? I think that question hasn't been formally, codified in a way into policy and into evaluations in a way that I think it should be. So when I say intention, that's what I'm talking about, not just like this nice sentiment. I mean, really hard coding it to say, we will measure and we will evaluate the success or failure of payment programs based on whether the benefit was equal, right? Whether certain groups that we know are historically marginalized or at risk benefit from these programs. And so I think that's probably the most important thing.
Well, and I think to your point about being intentional, you want to be thoughtful in how you design with the outcome in mind, I suppose, and designing how you get there to actually achieve that outcome. And I think it's important to talk about that intentionality behind any of the programs that would be put in place. How sort of in the short term and long term, are there certain goals or sort of, intentions that should be set for achieving, better, because I know this is not something that changes overnight, right? This is a long, knowing where you want to get to and then starting to take those baby steps and one step at a time. But, without setting goals or having an idea of where you want to get to, you're never going to get there, right? As long as that would never happen. And so I just kind of curious for you, how you think about what goals should be set to sort of better achieve health equity outcomes, across short and long term. How should we be thinking about that?
So I'm happy to answer that. I'm going to just go back for half a second to the point and say, I agree with you. And as simple as it sounds, I think intention always precedes implementation, or a lack of intention precedes implementation, and I think it's an opportunity, but it doesn't mean we sit there and just think for days and months and years. I think there are ways to do it in the short term, as you're saying, but it's incredibly important because I think oftentimes healthcare disparities, which again sits within the broader canopy of health equity and inequity, often is described, in conversation as an unintended consequence. And I have to say that notion to me doesn't sit well in the absence of evaluation, right? And metrics and things that we're doing. It's like, if we set an intention, at least part of that I think can be addressed. That doesn't mean any payment approach is going to be perfect, right? But we should evolve, in my opinion, over time to be directly intending to address inequity or disparities. And then if we learn over time, there are other things that we didn't intend and then you evolve forward. And that's the spirit of this. So what can happen? And I think we're seeing early examples of it. I think you can begin to identify measures and processes within payment models and payment mechanisms that can better address equity. So for instance, if there's an intention to focus on social determinants, right? But you look and say, well, quality metrics have nothing related to capture or assessment of social risk factors, right?
Yeah.
Nothing related to referrals to community organizations, nothing related to follow through for those referrals, right? Nothing encoded in care management or care coordination programs related to those social needs. Those are doable, right? I mean, they need to be vetted. They need to be thoughtfully designed, but those are doable. Groups are beginning to do that, right? And tying those metrics and performance on those metrics to financial incentives, right? So that's a relatively near-term thing I think that can happen. I mentioned this earlier. I think the other thing is to say, look, we're going to do a lot of programs, but I think it's incumbent on us to then evaluate all those programs, right? I'm always struck by the number of programs that are implemented. And when we evaluate them, we don't ask the equity question. And so we don't know. I mean, in some ways you don't find what you don't look for. And so I don't think it's actually theoretical for provider organizations, for payers, for those partnerships to say, when we're done with this, or at some midpoint, we're going to evaluate it. And when we do, we're going to put that lens on to say what happened to disparities. So I think that's the second kind of short term. Let me just highlight one long term, which is that I think when you think about the outcomes, cost and payment utilization is one, right? We want to contain costs. Quality is another. I think I would like to see longer term ways of encoding equity into that. And the reason I say that is that if we think about areas that are low value care, for example, or things that, we might be doing quote too much of, it turns out when you kind of like unwrap that, sometimes there are inequities there too. And I've shared this in other contexts, but an example would be joint replacement surgery. So getting a knee or hip replaced, an incredibly common procedure. If you talk to a number of people around the country, they'd say, man, this is something that we could probably make more cost conscious. And do we need to be doing that many joint procedures? Are we doing too many? Setting that clinical argument aside, I think what you find if you take an equity lens to it is actually certain groups, including Black and African American individuals, severely underuse those procedures. So if in an overall effort to try to say, well, let's curb the use of joint replacement procedures, right? Because we think certain groups use too much of it. If by doing that, you don't take an equity lens, you may actually be further suppressing what's already underuse, right? Among certain racial groups. And do we want to do that? And so what are the policy things that allow us to avoid that issue?
That's fascinating. So on the one hand, for probably numerous reasons, when it comes to joint knee replacements, African Americans are using it less. They're probably could benefit from that, care, and just not getting it. And the sort of blanket reaction of we should curb that would actually also impact, them as well. That's fascinating. And I'm sure there are examples of this across tons of other procedures and care that we deliver. Do you think but you had this interesting point that we're just not looking. And are there reasons why we're not looking? Has that started to turn, or what goes into that? Why?
So a couple of things. What you're describing is that thing I was saying a number of minutes ago about levels, right? About the subtle levels of it, right? You see that. But if you peel the layers back, there's all these levels to it. And so those are subtle, but important to kind of unearth and spotlight. I don't presume malice. I think really it's more just there was an intentionality around it, right? I think it's incredibly well-intentioned to say, we want to identify things that we do too much of and we don't need, and things we do too little of and we want to do more of in what I'll call an overall average way, right? What's the overall effect? And to try to address those. I think that's really well-intentioned. But in doing that, if you don't recognize what people like me would call heterogeneity or variation, right? And how people get care and the quality they receive and the payment and the spending, you miss something. And so the example I gave you is one. There are others. And that's what I mean when I say a long-term way to address it would be to bake what I just described, this intention and the prompting to look into not just a conversation we're having, right, on a podcast, but into payer policy, right, into legislation, into program evaluation requirements. That's incredibly concrete to me.
Yeah. And that's to your point, you have to bake that stuff in because if you don't, it'll never probably happen. And the incentives to change, won't also be there. It was like I was talking to someone on the show and they were talking about like case management and the reimbursement for case management, like almost wasn't there to justify having case management programs when you would do like the ROI on if we're going to hire case managers and how much they get reimbursed and all this stuff. And so what he was saying was, well, in order to if you care about case management and it works and it's important and you need it, then you need to reimburse and make it so that the incentive is there to make it a viable approach and program for organizations.
Yeah, no disagreements. But I think what that comment highlights is a few things we've been talking about. The first is this idea that one, payment is a very powerful motivator, right? In this case, whether you stand up or don't stand up certain programs. The second is that if everything is viewed through the lens of, does it save money or does it not save money? I think all of us across the health community, we've lost something, right? Something on the grounds of values, right? We should just do. And other things, I'm not saying just be fast and free with it. I'm saying you need to look at the quality and benefit gain per dollar spent. You can still be very rigorous about that. But in that view, it actually widens the aperture, allows you to see, hey, we should make actually investments in care management programs. The last thing I would say, that comment, which I hear often in my conversations, highlights is that I think part and parcel to that is if we're going to provide payment, I think we also need to ratchet up and make rigorous. What are we talking about care management? One of the challenges that the scope and the definitions of those programs and the methods vary quite a bit, right? And so I think one of the things, if I had the magic wand and said, could I pay for it? It is not the right thing. It's a plural. Like the case management looks very different across different places, right? So if we don't have some standards or some core approaches there, it's going to be hard to know what we're paying for. So, and I say that to say, it's not like we just say, well, we value it, let's just pay for it and then hope for the best. No, there needs to be, I think, rigor and clarity around multiple things. On the payment side, yes, but also on like, what are we delivering? And I think there's a ton of variation there too, sometimes.
Yeah, I would think so. And probably variation in cross geographies and all sorts of things. I think you could sort of maybe you touch upon this, sort of identifying sort of the measures and processes that would help better account for health equity. Are there a few that sort of that you're honing in on or that you've seen help actually improve sort of the move to having a more equitable health system when we sort of look at that through that lens?
Yeah. So I was fortunate to, with a few colleagues, really kind of start an initiative that we're calling Health Equity Payments. And it really encapsulates a lot of what we've talked about today. But one of the things I think in creating that and calling attention to this issue we've observed is that we don't need to reinvent the wheel. I mean, unfortunately, there are a number of places for decades we've known there's been disparities, right? And so getting back to the kind of flagrant versus subtle ones, if something is staring you in the face, I think there's an ability to go there. So in my context as an internal medicine physician, those often look like things like chronic diseases like blood pressure, diabetes, outcomes like that. You highlighted maternity care, right? And pregnancy, another really important one. So I think that's important. And the reason I highlight the initiative is that our intent in that work, my intent is actually to go and work with groups. So payers and providers and other organizations to actually address that, right? That's the intention here. And when we get together with them to do that, the question will be, as you say, because of the variation, what are the major issues in your communities right now? I think that's the starting point. In contrast to, I found the measure in every place, Boston, Seattle, everywhere in between, we can use that. I just don't think that's the right way for a number of reasons. And I'll add one, which is we talked earlier about public policymakers. We talked about providers. Where do payers that are more regional or have regional coverage play? I think this is a critical role there, right? If I was looking for a group to understand across a covered population, knowing comprehensively their data, where the areas of inequities are, I think the payers play a key role in that, right? And so going back to your question, I think you would start there. And that's certainly the type of thing that we're trying to do in our work.
Yeah. And so is that with the payers, like looking at like their claims data and things like that, or what are sort of those data streams that would be relevant to this conversation?
That's right. That's right. And I'm going to say something that you probably know well or other guests have highlighted, but
so you give me too much credit.
Well, okay, that all of us can learn more of. In that way, I think, we have incomplete data oftentimes on the provider side of things, right? So I think it's incredibly important to be able to get insight from payer data, right? And how you operationalize that, data sharing, they do it. It doesn't, I think that's less important to me, but they provide an incredibly important lens to where the gaps are, where inequities are, and therefore where the opportunities are. And that's what I meant when I said, I think all of these different stakeholders have a role. I think that's a key part of what payers can do.
Yeah, that's incredible. Josh, this has been very informative for me. I know I've learned a lot. Where can people go to learn more about your work and in this topic and to kind of follow the stuff that you're doing? Because it's really important. And I think it's hard to have a conversation like this. It's an ongoing conversation. It's not like a one-time thing. But so where can people go to learn kind of more about your work and this topic?
Yeah, thanks, James. So let me highlight a few. So the first, and I'm happy to add any of these to the show notes if that would be useful. But yeah, the first is to visit healthequitypayment.org. That's health equity payment, no spaces, nothing like that. And there, I think people can learn more about the work we're doing. Currently, the thing that's there is an open letter that essentially is a call from myself and others across the community in healthcare to say the things we talked about over the last 30 minutes, we need to do this. And we've been really fortunate to have a range of individuals and organizations, professional societies, provider organizations, payers, their leaders, frontline clinicians, advocacy groups sign on to that letter. We would welcome any and everybody who wants to join that call, who resonates with that message to join that. When they do that, there's actually an ability to kind of sign up for essentially an email list to find out more as we're doing pilots, as ways to engage, because as you say, it evolves over time. So number one is to visit that webpage and consider signing the letter and signing up for updates and ways to engage. That's number one. The other is to visit, my group at Vessel, or the Value System Science Lab. That website is vsslab.org. And, the work that I and partners do through that capacity is to say, okay, you have a program now and you want to evaluate it and you want to take an equity lens to it. What would that look like? How would we do it? What are the limitations to that? We are often, really fortunate to work with different groups in that way, including provider systems as well as payers. And so would be another way to do it. And then finally, the third is I think it's going to really, truly take all of us. So if there are people that would be interested in reaching out on a more personal level and to learn more about this, I'm happy to engage people. But those two websites, I think, provide a starting point.
Awesome. Well, it's a no-brainer. I'm going to go sign up as soon as we get off this recording. So Josh Liao, MD, thank you so much for making the time to I feel like we barely scratched the surface of this, but I'm just so appreciative of you sharing your expertise on this topic. So, thank you for making that time for us.
No, James, thanks for having me on the podcast, and thanks for featuring this issue. As you say, I think I would love if we got together again via podcast or in person one day, that we could look at all the progress that's been made. I hope that's the case. The topic is big enough and important enough. So thanks for having me join.
Thanks so much.